in the beginning of the LAD. Go ahead, Rahma. Yeah, you can see here, Rahma, I don't know if you can have the pointer right there. Yes, exactly. So clearly, if you can keep them playing, so we can show these images.
I should go and back.
Right there, you can see it's very ostial, very close to a left circ and ramus, and heavy thrombus burden. Of course, in the setting of a patient who has an anterior STEMI, a bad anterior STEMI, and is becoming early hypotensive, so which is a worrisome sign, and even his heart rate's a bit on the higher side. Go ahead, Rahman.
Okay, as Dr. Qais said, again, the severe thrombus burden at the ostial LAD can be appreciated, and multiple angiographic views were obtained to better assess lesion morphology, thrombus burden, and relationship to the bifurcation. So, at this stage, what would be your preferred strategy? Doctors, feel free to open your mic and let's discuss your initial thoughts or strategy for this case.
I think we have a couple of minutes here that we can talk. So, we have a big clot sitting right at the ostium of the LAD.
Qais, may I interrupt you? Can you just put the image which represents what we are going to discuss rather than the slide? Just keep the image running while you're talking.
Yeah, Rahma, if you click on it, you don't need to go back and forth. You just click on it and it will run back again. And focus on the one, yes, this one. Keep this one running because it's kind of obvious. So we have this big clot right at the mouth of the LAD, very close to the left main, and where the circ is coming off, patient is not doing well. So what would be our next step for such a lesion?
Hi, Qais. I got a couple of points here. What's the duration of the pain between the onset of pain and the patient coming to the hospital?
Yes. So the pain was a stuttering. You know, when we talk about the stuttering MI since the morning on and off chest pains that is getting worse. But the big event was around 30 to 40 minutes before he came to the emergency room, where the pain became constant and very severe.
My second question is the morphine with the pressure of 95 systolic, was IV fluid or ringer given prior?
So I'm not sure. I'm going to be honest. This patient was not my patient. It was a patient in our institution, but he's not my patient. The guy who did it kindly gave me the case, but I'm not sure. I can't answer that question. I think usually our protocol in our ER is that we usually, for all hypotensive shock patients, we give them an early IV fluids resuscitation. Not too much, but at least 250, to kind of 500 cc bolus. Regardless of etiology, even in cardiogenic.
My third question is, I'm going to steal Dr. Hadi's point. Was an echo done before the patient had a cath?
No.
You knew I'm going to say that.
I have a question from my Qais.
Yes.
So Qais and Rahma, nice presentation. I think we should not keep repeating cardiogenic shock based on blood pressure reading, because this is falling out of text here. The blood pressure of 95 is commonly seen with our patients on multiple medications. The question is, was he in a clinical cardiogenic shock? Refill time, organ perfusion, kidney function. That's now how I look at cardiogenic shock rather than on a blood pressure systolic of 95.
Okay. So no, he was not in the classical. He was not in the classical sense of a cardiogenic shock. he probably was in stage B, beginning. He's starting to become hypotensive. Okay. He's not where, you're...
Is my voice... Do you hear my voice?
Yes, yes.
Oh.
Go ahead, Dr.
Allow me, Qais. Mustafa, I think it's either you are hooked up to two, maybe from your iPhone and laptop together. If that happens, you will have a big noise coming out. If you are hooking up from two devices.
Yeah.
Okay, you have to hook up from one device.
So we have to finish up the case. So just to kind of keep time and not waste too much time, we have discussion points coming up. What would be the next step? Just kind of, thinking out loud.
I mean, this is very proximal to the left main. The worrisome is if you put a wire, you might, the clot or the haziness, whatever is there, might migrate proximally, and then you'll have a disaster. I see the flow. I don't know. I see the flow looks like a TIMI 3 flow. So I think one school depends on the, we don't know the patient. We didn't see the patient. Some people might want to try, like a 2B3A for 24 hours, while the patient is being observed, unless he's really crashing on the table. But there is always the fear of clot migrating proximally and causing total inclusion of the left main or showering, the clots to the circ. And then, but the flow here doesn't look really bad.
Mm-hmm.
Okay.
Kind of
if I may,
this is the, can I say?
Yes.
Can I talk? As Dr. Ayman said, the flow is disproportionate to the clinical setting of. I doubt now if his ECG right at this time is still having ST elevation. And I don't know whether the patient is still in pain with this TIMI 3 flow. The thrombus is there. But the flow is TIMI 3. Now, when we have big burden of a thrombus, the challenge is not only opening the vessel, but restoring the microcirculation perfusion while minimizing distal embolization and unnecessary stenting. Once you restore the flow, I think here comes the pharmacological driven therapy. Because it's not only mechanical, and we know that thrombectomy has class 3 now because there is no proven benefit in terms of mortality and more stroke in total and in test studies. I think defer the stenting after the resolution of thrombus and definitive stenting. I think this is the approach. I'm very impressed with the presentation of Rahma. Thank you. It was a great presentation. Thank you.
Thank you.
Yeah, can I just add? I'm going to add one line. Routine aspiration is class 3.
That is correct. Routine. Bailout is okay, and I'm going to talk about that. Routine
can I have my approach? If you don't mind.
All right. So, Rahma, go ahead. Move forward so we can actually finish with time.
Sure.
Do you mind if I give you just a hint here?
Yes.
Can you hear me? So
yes, I can.
This is in fact might be a simpler case than we imagine. If you think it is a cardiogenic shock, you just go ahead, get a femoral access, put an intra-aortic balloon pump, double wire, do an aspiration as this is not a routine case, and do stenting. That's what my approach. This patient is having ST elevation MI. with failure of reperfusion, and I'll do this case. Now, had he not been in cardiogenic shock, I'll just do the simple case. Guide, 2 wires, a stent. We do many cases of these thrombus heavy burden lesions, and most of the time we go without complications. That's my approach.
Thank you. Thank you. And as I said, I don't think he's in the classical frank cardiogenic shock definition yet. He's in the beginning, you know. All right, go ahead, Rahme.
Thank you all.
Qais, before Rahme goes ahead, we have our colleagues from Asia with us. Maybe they want to give us a feedback on what they'd like to do.
We appreciate that.
Can they hear us? I mean, is there...
Me, doctor. I am Abdullah Mansour.
Please.
I am a medical student.
Yes,
I
yes.
think...
No, we're talking about our Chinese colleague, Dr. Abdullah, if you don't mind.
Okay.
Yeah, thank
Now,
you.
I mean, our colleagues from the Asia Heart, I mean, if they can hear us, I mean, it will be nice, but it's a joint meeting to see what they think, how would they approach the patient.
Okay, distinguished professors, I'm Dr. Cao from the First Public Hospital of Harbin Medical University, and I'm privileged to join this online session discussion. So I'll keep it short. I think this is a wonderful case. I mean, from angiography, it seems to be very large thrombus at the ostium of the RAD. However, I mean, still, I mean, hard to say whether it's a calcium nodule or anything else. However, I think this is a typical STEMI with the blood pressure, I mean, not so good. So I think several things should be done. I think for me, I will agree with the previous options to maybe put IBP standby, at least to the femoral sheath in the femoral artery to stand by for the potential IBP support. This is one choice. The other thing is that recently several evidence from China indicated some potential, therapy for the intracoronary thrombolysis. I think this is a potential choice. Maybe, I mean, some chance to reduce the burden of the thrombus. I mean, yes, this is only one choice. But however, before this, I will try to use, working horsepower in the circ, in the RAD, try to use the thrombus catheter to, try to reduce the burden. But this is all, you need to put your hand on the case and see what's the reaction of the patient. I think this is my opinion. Thank you.
Thank you. Thank you. Thank you so much.
Thank you, doctors.
Right.
And thank
Yes,
you for your...
go ahead.
Okay, so as we said, and as you all give the answers, each strategies carry advantages and limitations, especially in the setting of a larger thrombus burden, and will not say cardiogenic shock, you will say instability of the patient and hypotension. So here, the major challenge was the very large thrombus burden. The potential concern included distal embolization, proximal also embolization, embarred distortion of the flow, and the stent challenges itself. So the challenge was not simply the stenosis itself, but the amount of the thrombus present. The stenting over a large thrombus may result in stent malposition and maybe increase the risk of future stent thrombosis. So initial aspiration thrombectomy was performed in an attempt to reduce thrombus burden. However, a significant amount of thrombus remained, so all the routine thrombectomy is no longer recommended for all STEMI patients. It may still be useful in okay, تفضل دكتور قيس.
Yeah, go ahead. No, correct. Go ahead.
Okay. I was say it may still be useful as payload strategy, as you said, but in a selected patient with a very large thrombus burden. So here the manual thrombectomy was done. Although thrombus burden was reduced, complete thrombus removal was not achieved. Here's the angiogram again.
And as you notice, we've actually both wires have been protected. Both vessels have been protected with wires. Then next, Rahmet.
Go ahead, doctor.
No, go ahead.
Okay, this is the mid-distal lesion, was stented also. A significant lesion in the mid-distal LAD was treated with the stent implantation. And this is the PTCA to ostial LAD. Balloon angioplasty was performed at the ostial LAD lesion also. And the main point, thrombus still there, dissipate thrombectomy and balloon angioplasty, a substantial residual thrombus remained. So this illustrates one of the major challenges actually of STEMI intervention when the thrombus burden is extremely large. So at this stage, I can say this operator faced a difficult decision. Waiting longer could delay the reperfusion, while proceeding carried the risk of distal embolization. So because, let's say, ongoing ischemia and instability were the present, definitive PCI was pursued. So again, let's discuss again another important question.
I think for the sake of time, we're going to move forward because we're limited on time. Go ahead.
Okay.
Yeah.
Just, okay.
Okay,
Here the stenting with the LCX protection. So the lesion involved the ostial LAD. Let's repeat it. Near to the LAD LCX bifurcation, so therefore LCX protection was performed during the stenting. So I'm not
not only did the operator here also choose to protect the circ, given the heavy thrombus burden and their worry with a wire, they even put a small balloon. I don't know if it's obvious on these pictures. They also put a balloon down the circ in case they needed to do a quick balloon angioplasty, or if the circ, they have difficulties advancing any equipment later on. That's an extra step. The vessel seemed fine. The flow was good. I'm not sure it was completely necessary, but it's a good idea and it's a nice idea.
Yeah, as you said, Doctor, this approach allowed treatment of LAD while maintaining immediate access to the LCX if side branch compromise occurred. So this is post-stent results following stent deployment and angiographic appearance improved significantly, can we see, with the restoration of coronary flow. So maybe I can say at this point there was no need to convert to the two-stent strategy because the side branch remained preserved. This is my opinion, Dr. Qais.
Sure. Always provisional stenting is the way to go if you can, do without multiple stenting and complicating the bifurcation, especially that this is actually a trifurcation, not a bifurcation. Go ahead.
So this was the final angiographic result. Good vessels patency was achieved with successful reperfusion. So the procedural goal was restoration of coronary flow while minimizing the complication. And here is again.
Thank you. Next.
So post-procedure echography demonstrate a reduction in ejection fraction to approximately 30 to 35%, with regional wall motion abnormalities consist with anterior infarction. That's what I can see, what we can say to this case. And this reflects the extent of myocardial injury caused by the infarction. And this is the hospital course. The patient was monitored in CCU because the patient also persistent thrombus burden. Tyrofepan infusion was continued for 24 hours, and minimal vasopressor support was required initially and was successfully discontinued the following day. So I can comment here the decision to continue tyrofepan reflected ongoing concern regarding residual thrombus. So the patient improved clinically and was discharged home on guideline direct medical therapy. This is the guideline direct medical therapy. And as take-home messages, large thrombus burden requires an individualized procedure strategy. Aspiration of thrombectomy may still have a role in selected STEMI cases, despite not being routinely recommended. And again, as Dr. Qais said, provisional stenting remains the preferred approach for most lesions. So the case illustrates the successful STEMI intervention is not only about opening the artery, but also about choosing, let's say, the safest strategy in the presence of extensive thrombus burden and the hemodynamic instability. So for now, thank you, and happy to hear any question from you.
Thank you, Rahma. Thank you. Appreciate it.
Thank you, Rahma.
Thank you. Dr. Jamal and our esteemed panelists and moderators and colleagues, would you like to discuss any more questions about this case, or should we move ahead with the brief didactic, and then we can come back and open the discussion overall? Which way would you...
Excuse me, may I give some comments?
Yes, please.
I'm Liu from China. Okay. Nice to meet you all. And I do think this is a very wonderful case, and the final result is really good. Congratulations. But I have some comments. So first is really for the according to the basic angiogram, we can see a very easy imaging in the ostium of the LAD. But I do think for this kind of lesion, I suggest to use intravascular imaging to make sure it's really thrombus, or like some other kinds of lesion, just like just now Professor Chao Yang said. Sometimes the calcium nodule lesion also look like thrombus, very easy. And for the like this should be a left main lesion, because of the lesion is at the ostium of the LAD. So I do think the intravascular imaging technique should be used. Next point is, if really the easy lesion is thrombus, so we should try our best to get rid of the thrombus. So also the routine thrombus aspiration is not recommended for all the STEMI patients. But if there is really high thrombus burden, we should try to take the thrombus out. But one thing we should pay attention, I totally agree with the operator to put another wire in the circ. So one thing is when we do the thrombus aspiration, sometimes we make the thrombus drop into the circ. There should be a iatrogenic complication. So if there is a wire in the circ, we could use the thrombus aspiration catheter to take out of the thrombus from the circ. So this is a good choice. But if the at the ostium of the LAD real huge thrombus burden, there is still another technique could be used to take out the thrombus if the routine thrombus aspiration catheter don't work. So about I think should be more than 15 years ago, in my center, we began to use the 5 French child catheter to take out of the refractory thrombus, because according to the Poisson law, so the efficacy of the 5 French child catheter, the efficacy is about 3.5 times of the routine thrombus aspiration catheter. And we have used this technique in many refractory STEMI cases. So it is very effective. So sometimes even better than the angiojet, because angiojet is available in my center. So if it is really a huge burden, I suggest to use this technique. So that's my opinion. Thank you.
Thank you. Thank you for your amazing opinion. And actually, I agree. You know, as far as the IVUS imaging, definitely it makes a lot of difference, and it's very important to differentiate from other important differential diagnosis. Unfortunately, in this center that this procedure was done, IVUS imaging is not available in the non-working hours, because it's usually kind of arranged beforehand for elective cases, but not on regular routine basis. So that's why probably IVUS was not done. I totally wholeheartedly agree that protecting the circ was a must and a mandatory thing. And I love the idea of the daughter catheter in cases of difficult scenarios. Appreciate it.
Qais, allow me, Qais, just to make a couple of comments. Dr. Yuli, I mean, it's a great comment which you made, and if my colleagues allow me, just the way I see these things is just we learn from each other. I mean, the first learning point, which my colleague Ayman Hamdan made me laugh, the value of the echocardiogram in those patients is invaluable. If you knew ahead of time that the ejection fraction is 30 to 35%, you probably would have pulled your sleeve up and be a lot more cautious in your approach, having the mechanical support available, etc. I think that's very, I mean, in my opinion, and I always say, there isn't a lot of excuse of not doing an echo before doing a STEMI, unless the echo is not available, because it really gives you a lot of information. I mean, assume you have a big mitral regurg there, which you, I mean, it's always informative. Yeah. So this is one. The other comment I wanted to make, as my colleague Dr. Qais mentioned, this is a trifurcation lesion. It's not a bifurcation lesion. And I would have protected that large ramus too as much as I would have protected the circ. This is minor. The other major thing which needs more discussion is you did the stent in a way which we call a precise stenting for the ostial LAD. I think this needs a lot of discussion. Is this the best approach to approach ostial LAD and ostial circ or not? Is it the one which has a better outcome, yes or not? Especially if you don't have imaging. As Dr. Yuli said, I mean, what you have, Qais and Rahman presented that, I would not venture to say this was a clot. All what I would say that there is a haziness, a major haziness, with the flow going through that haziness, which leads to a TIMI3 flow, as my colleagues mentioned. So equating this, a filling defect with thrombus, at times you sail safely in your case, but at times you might not at all, because you don't know what's in there. And as Dr. Yuli said, and with my understanding, Qais, that there is no intravascular imaging there, but let's assume we have it. Intravascular imaging in this patient is a must, because it will tell you what you're dealing with. It's very, in my opinion, it's very important. And now the point is, which I'd like you guys to discuss, it's not that a two-stent strategy or provisional. You did not do a provisional because you did not cross the left main. All what you did is a precision stenting of the ostial LAD, my friend. So it's not a provisional. I'm sorry, Yani. So the terminology is not
exactly a bifurcation,
it's
a precision. Yeah, I got you.
Yes. So you precisely put it at the. I'm just discussing this out of science, by the way. You know me, Qais. Yeah. So we have to discuss now: is this the best approach for ostial LAD or ostial circ? I mean, that's important. Thank you very much.
Can I make, if I give a comment just to thank Professor Yuli, Chair of the Interventional Cardiology Council of the Asian Heart Society, for your valuable comments and insightful perspective, Professor. And we are honored really by your participation in today's session. Just this comment. And I think if Professor Kao he is an expert in intravascular imaging. If he can give us a perspective on that, I don't know. Or Qais, if he's not there, you can go ahead. Okay.
He might have stepped away. All right, so let me, yes, go ahead.
I have a small comment, Dr. Qais, if you allow me.
Yes, yes, and then maybe I'll proceed with the next part for the sake of
whenever there is a big burden of thrombus, I try to minimize the manipulation at the area of the lesion. I wouldn't go with angioplasty. I would go with direct stenting to the vessel to catch any thrombus from more to minimize, let's say, distal embolization and no reflow that usually or that is a common thing to happen during this kind of PCI.
Yes, thank you. If you would allow me to share my slides, then I would proceed with the next part. Can everyone see my slides or not yet?
Yeah, they're clear. They're clear.
Here, good.
Yeah, you can see it, right? Everyone can
Not
hear
anymore.
me? Not anymore?
Yes.
Oh,
Yes.
Yeah, we don't see your, you didn't see your slides now. We don't see your slides.
All right, let me try again. Maybe it doesn't work that way. Okay, and all right, now.
No.
It's still loading for me. It was there for a second, then went away.
Okay. The promise. How about now?
No, it's not there.
Problem is I have multiple slide monitors here. So let me just do this.
Hello.
Yes.
يا هاي بيبي نايم عند أول. قولي لها هاي لجوجو.
Dr. Auni, mute your phone.
All right. So what I'm going to do is, given the fact that I have multiple monitors and it's projecting to somewhere else, I'll just do it this way. You all can see it this way, right?
No.
You can't see my slides?
No.
I can see them in the screen sharing. Why are they not showing up?
No, I don't see them. I don't know. Anyone see them?
The very first time it was, we were able to see them, but not anymore.
Dr. Qais, you can share it with me. I can do the share screen.
Yeah.
Okay. Hello.
Okay, I sent it to you.
Yeah, we'll share.
Can everybody mute his phone, please, and let just only Qais be on the unmute button?
I think I know why. Share, and then
Yes. Now.
PowerPoint.
Now we can see the Qais.
No, it disappeared. It disappeared again.
Okay, can you see it now?
Yeah, I can see it.
Everyone can see it?
No,
Yes.
I don't see it.
How many can see it?
Dr. Hadi, do you see it?
No, I don't have. I don't see the slides now.
Rahma, go ahead, do it yourself. I don't know why.
Okay, never mind.
Okay. Sometimes when you have multiple monitors, you need to click the software. Maybe it's waiting for your choice to choose the monitor that you want to choose.
I need to choose the monitor, yes.
Dr. Qais, كان مبين عنا.
Yeah, well,
okay, it's fine.
It's fine. Go ahead. I don't want to waste time. It's enough time wasted on something.
Just I need someone to give me the request, to accept my request, to share my screen.
Recording in progress.
Okay.
Yes, it's okay.
Go back.
It was there. Now,
Are you going back?
Yes. Yes,
Everyone can see it?
Yeah, but it's not full screen.
Yeah,
Yes.
it's a full screen. No, it's a full screen. All right, I'm going to go ahead.
Yes.
Go ahead, guys. It's full screen now. It's fine.
Yes. All right, so we're going to talk about contemporary STEMI interventions beyond primary PCI. Next, Rahmi, please. So the idea is although mortality has been reduced in 2026 from STEMIs, it still remains complex. And in a lot of cases, this complexity is further complicated by shock or mechanical complications. So although we have better tools, although we have better approach, better understanding for STEMIs, it doesn't mean that STEMIs are not challenging or STEMIs are innocent. They still can be really difficult. And as a matter of fact, I just had one today, which was very difficult. Next. So what are we going to focus on? We're going to talk about identifying some phenotypes of STEMI that are critical, apply some contemporary strategies, recognize shock early, and manage some of the STEMI complications. Next. All right, so the STEMI journey. The STEMI journey, and this is an important concept, that it's not just in the cath lab. As a matter of fact, it starts right at the patient's home with symptom onset. And this is a critical point that we need to always focus on and maybe go back and educate our patients that the earlier they come to the ER, the better the STEMI survival. It's not just about time is muscle. The nature of the clots, the complexity of the lesion becomes much worse as time progresses. Of course, at EMS and emergency department, the faster they are, the more protocol, they are more efficient and more likely to be successful. And then the second part, even when we're done in the cath lab, even if we opened up the artery, quote unquote, the further recovery of whatever complication, whatever shock state, whatever organ dysfunction the patient has is critically important, and all your good work and all the nice vessels in the cath lab can go down the drain if we do not have a proper recovery, proper post-care for the patients. So successful PCI is not equal to successful STEMI care. Next. So what are the points that we need to talk? So again, we're always focused on our cath lab and getting the artery open. So yes, we want to have an open artery, but did we actually improve survival? Are we managing all potential complications? Did we preserve the myocardium? Are we having enough perfusion to have a good heart muscle afterwards? And are we preventing shock? Because that significantly correlates with a poor prognosis. And the more delayed the presentation is, the larger the thrombus burden, the more distal embolization and poor flow distally and incomplete perfusion we have, the worse is our STEMI care. So it's not just about opening up the artery, it also has to do with how the muscle in total is doing, how the care before and after is. Next, please. So let's talk about some high-risk scenarios and how can we navigate them. Next. So first one, like our case, which was a large thrombus burden STEMI. There is this TIMI thrombus grade classification. Grade 0 is basically no thrombus. Grade 1 is when we see a very mild haziness, like the second lesion, the one which was the proximal mid lesion. Maybe that's a bit hazy, irregular contour. Grade 2, you have a definite filling defect, a thrombus, but the dimension is less than half of the vessel diameter. Grade 3, it's more than half, but less than 2 vessel diameters, as in length. Then a grade 4 and grade 5, which we consider large thrombus burden, is when you have more than 2 vessel diameters or a total occlusion. Having said that, this is after you pass your wire. It is not before you put the wire. This is after passing the wire, but before doing any balloon or intervention. And I agree with Dr. Yuli, and I agree with Dr. Hadi. IVUS is critically important to actually give you the diagnosis. And not only IVUS, we could use even OCT if you have that tool. But you're not always lucky to have that all the time. Next. So what does large thrombus burden cause? It causes distal embolization, slow flow, microvascular obstruction, and acute stent thrombosis. So you can see this is a really nasty disorder, nasty disease. It can lead to a lot of problems that are difficult to fix. You know, sometimes if I have a dissection, I could put another stent, kind of easy to fix. But if I have slow flow and it doesn't respond, it's really it's really a nightmare for an interventionalist. Next. So, next, please. So how do you manage? There are different ways, but this is usually the way that I like to look at it. So it's a kind of graded response. First of all, usually you should use the usual techniques. So again, routine thrombectomy is not indicated. But as Dr. Yuli said, and Dr. Raed, bailout is a very much strong methodology to treat thrombus. But of course, first of all, we start with wiring and we start with simple ballooning. Then we move on to aspiration thrombectomy, usually manual aspiration thrombectomy. Next, please. So it is usually, no, go back. So it's usually a bailout for residual thrombus after we've tried initial ballooning. Routine use is not recommended, and there are some tips that I want to focus on. So when we advance the catheter, it should be under active advancement, meaning there is suction while we're going in. And also, when we're bringing the catheter back into the guide, we should make sure that the guide is deep-seated, so there is no potential space between the aorta and the left main, so that there's no embolization and potential stroke formation happening. The other thing is it should be always continuous aspiration until you exit with the catheter to the hemostatic valve. So no residual thrombus stays in the guide. And also, even after doing that, you should rigorously back bleed the guide and make sure that you've completely emptied it. So no residual thrombus is there, and then you re-inject it. Even worse, you re-inject it into a normal vessel. So that's some small tips. Next one, please, Rahma. Mechanical aspiration devices can provide continuous aspiration. There's minimal data. One prospective registry showed it does improve TIMI flows, but comparative data is lacking. Next. There is a new technology. Actually, our colleagues in neurology use it a lot for strokes in the brain, which is the stent retriever. That's a new device that they actually go over a wire, small tube into the vessel. They open it up as like a mesh. Then they pull it into a bigger tube. Retrieve AMI showed that actually there's 3-4 more thrombus volume. And as you can see here in that trial, it actually did correlate with better than no thrombus, but minimal impact on no reflow in comparison to manual thrombectomy. Next. The other one is the intracoronary pharmacotherapy, the ones that we were talking about just a few minutes ago. Of course, you know, glycoprotein inhibitors are a very strong agents, and we can use them frequently, either intracoronary or also later on as a couple of days and then coming back. And as Dr. Yuli mentioned, intracoronary fibrinolytics have a reserve, especially for large thrombus, no reflow despite aspiration. And there was a meta-analysis on 12 randomized trials, which showed it is improved TIMI flow grade and ST segment resolution. So that's another good alternative. Next. Excimer laser is usually very limited and it's not usually available. But finally, what we talked about, the deferred stenting, and there was a trial, next please, Rahma, which is Dynami 3 deferred trial, showed that routine deferring 48 hours did not improve the composite death. However, if you took a special subset of those patients, the ones who had long lesions and required long stenting, those actually on CMR had less infarct size. So it is a methodology that you can use, but it has also some caveats for it. And And of course, I'm talking here about deferring stenting, not deferring optimization of stenting, which is another topic and it's currently being evaluated. Next. All right, no reflow. I'm going to go fast for the sake of time. Basically, it's a bad nightmare for an interventionist. Diagnosis can happen in the cath lab or through other imaging. The key point is prevention, because you really don't want it to happen. And you want to do everything you can do for it not to happen, because if it happens, the treatment options are there, but are limited. You could use intracoronary dilators like adenosine, nitroprusside, nicardipine if blood pressure allows, for nitroprusside, of course, and verapamil if the EF and the LV function allows, or the rate. But all of these help, but they really don't solve the problem, and still you have issues sometimes, frequently. Of course, exclude pericardial causes. Next, please. So, no reflow. There's a lot of pathophysiology. For the sake of time, I'm going to skip it, but we should always look for risk factors. Make sure, because then we can prevent. Those patients who have high risk factors, we should prevent. And those are the patients that have longer ischemia time, high thrombus burden, LAD culprits, and absence of pre-infarct angina. How can we prevent it? Minimize ischemia time. And we're not talking only about door to balloon here. We're talking about educating our patients to come as soon as they have symptoms. Pre-procedural statin loading is a very important, and a lot of cases not really. We load our patients with high statin, but not in the ER. So we're talking here pre-procedural. Acute glycemic control, of course, intracoronary vasodilator prophylactically, not after it happens, and thrombus management. A nice risk score is actually the next, please. The piano score, which has the same elements that we talked about before. All right, managing no reflow, we talked about the vasodilators, but we should make sure that it's preferable to have distal delivery via microcatheters, and of course, keep an eye on our hemodynamic status. Next. All right, so pearl number one, goal is not opening only the artery, you need to restore myocardial perfusion. Next. All right, so how about shock patients? Cardiogenic shock carries a higher mortality. It is a serious disorder. You want to avoid it, and it frequently happens with STEMI. Next, but what we really need to do is recognize it early. So this is the SCAI classification. A is at risk, B is the beginning, classical form, D is deteriorating, and A is extreme. Next. Rahmeh, more than one. So I think the key point is really not reaching number E. Number E, if you're forced into it and the patient comes to you, then you have no choice. But you really want to pick your patients in A and B. You want to make sure those patients are taken care of and are aggressively treated and properly treated before they get to the further stages where prognosis becomes poor. And this is where key point comes in, and you can avoid a lot of hassle through that. Next. Next, please. All right. So there are a lot of trials about managing shock. Do we fix everything or not? Now, the consensus is you only fix culprit vessel in shock according to culprit shock trial. Then you could stage the further revascularization. Mechanical circulatory supports are useful, but if available. Unfortunately, in our center, we only have intra-aortic balloon pump, which has limited usefulness. But if you have other options, it would be very helpful, especially in the advanced stages of shock. Next. For the sake of time, I'm going to skip this one. Next, please. All right, so pearl number two, shock before hypotension appears. Recognize it early and treat it. This way, you avoid the hassle, especially in resource-limited scenarios where you don't have those toys. Then it's the key point to treat it early on. Next. All right, multivessel STEMI, do we fix all of them? So one quick point I wanted to make sure here is that not all STEMIs are equal. So STEMI with shock, yes, culprit shock tells you don't fix except the culprit. But multi-star says actually you could do non-culprit lesions immediately if your patient is stable. Complete trial also gives you a segue that if you want to stage it, it's also a possibility. So both are acceptable, but definitely not in shock. Next. So not all STEMIs are equal. It depends whether you're stable or not. All right. All right, this is a long one. It's basically summarizing what we talked about, top 10 STEMIs mistakes. We focus a lot on door to balloon rather than the total ischemic time, which actually correlates with poor prognosis. TIMI 3, opening up the artery, does not equal good reperfusion. Large thrombus burden can be a very nasty thing. We need to treat it always and take good care of it, and maybe even image it more, as we said. Recognize shock as early as possible. Echo, as Dr. Hadi was saying, to recognize mechanical complications early, and don't ignore no reflow. That's a serious problem. It's a mortality signal. You should treat it as much as possible, and better yet, prevent it. Next, Rahma. So our last 5 points. Primary PCI is only the beginning. Opening up the artery is only the beginning. The idea is to have good pre-perfusion. Thrombus burden is a very important point. Recognize shock early and be aware from complications. Next. Thank you so much. I'm sorry I had to go through it quickly, but I don't want to burden you with a very long presentation.
Thank you, Qais. Thank you very much. And thank you all for your valuable participation and contributions. Actually, on behalf of the Jordan Cardiac Society, I would like to extend our sincere appreciation to the Asian Heart Society, the ACE PCI program, and all faculty members for making this session success. And we look forward to continuing this fruitful collaboration and to meeting again in future scientific activities. Yeah. Thank you all and have a wonderful day. Thank you.
Thank you, everyone.
Thank you, Dr. Qais. Very, very nice talk. And I would like to take this opportunity to thank Dr. Yuli for hospitality while I was attending the Great Wall of China Congress, for your hospitality. I was at that dinner when we took a photo together. Thank you, Dr. Yuli, again.
Thank you. Thank you, Dr. Yuli. Thank you, Dr.
Okay,
Mustafa.
thank you. So really, I do think so today's meeting was a complete success. And on behalf of the Interventional Cardiology Council of Asian Heart Society, I would like to express my sincere gratitude to all the Jordanian moderators and the speakers. Thank you very much for your excellent speakers and discussion. So really looking forward to future cooperation in the future. Thank you all. Thank you very much.
Thank you.
Thank you, Professor Yuli. Thank you all.
Okay, bye-bye.
Bye.
Thanks a lot.
Bye.
Thank you, guys.
Bye.
Bye-bye.
Thank you.